Hello and welcome to the GHAPP MASLD and MASH Community Network meeting with Anthony Derencius. My name is Lauren and I will be your moderator. I'm joined here virtually by our presenter, Anthony, and now I will pass things off to him.
Thank you so much, Lauren, and I appreciate everyone who might be listening on this at a later time. Let's go ahead and get started. We're going to be discussing in a case-based manner, a little bit about lifestyle management in the management and treatment of both MASH and MASLD. I am Anthony Derencius. I'm currently a PA and sub-investigator at Pinnacle Clinical Research in San Antonio, Texas. My background includes both general and transient hepatology as a PA. Definitely a lot of patients with MASH and MASLD in my experience. If you want to register, here's a QR code, and then this presentation and others, kind of through the encouragement and support from Madrigal Pharmaceuticals, you can go to this GHAPP MASLD MASH Community Network, and you can see this talk and other disease state education at that same site. So for our case today, and kind of to put this in real world kind of perspective, I want to bring to your attention a case for Mr. Albert here, a 65-year-old male patient who has a medical history of obesity, and he was referred to your clinic for both elevated liver enzymes and abnormal findings on an ultrasound, which showed increased echogenicity, and the radiology report showed it consistent with steatosis or fat in the liver. He is Hispanic in ethnicity. His BMI is 29, so this is just regular, actually this is overweight going into obesity. He doesn't drink any alcohol of significance since he was in his 20s. His other medical history includes type 2 diabetes, hypertension, hyperlipidemia. On examination on first visit, you really just note some abdominal adiposity, but there's no real stigmata of advanced liver disease, and his BMI is consistent with that BMI of 29. On laboratory assessment, you see his triglycerides are 89, his HDL 41, hemoglobin A1C of 7.2%, and his ALT has been shown to be elevated actually for several years on review, 1 to 2 times the upper limit of normal. And further evaluation of other causes of chronic liver disease, such as viral hepatitis or autoimmune liver diseases, is negative. Based on his imaging, based on his laboratory tests and his risk factors, he does fit the diagnosis for metabolic dysfunction associated steatotic liver disease, or MASLD. Updated labs will show an ALT 43, AST 38, platelet count of 170. By using his lab tests specifically, you calculate a FIB-4 score. 2.22 is the result. And using that FIB-4 as a kind of a non-invasive fibrosis staging tool, and kind of looking at this flow chart and algorithm, we recommend that patients that are at risk for MASLD, or formerly known as NAFLD or NAFLD, non-alcoholic fatty liver disease. It's been recommended in primary care and endocrinology settings, along with GI and hepatology, to kind of identify patients at risk and to determine, could they have degrees of fibrosis, and or, we're trying to determine if they might have MASH or metabolic associated steatohepatitis. So this patient does have risk factors. He does not have excessive alcohol intake. If I look at step 2, blood count, liver function tests were performed. So we did step 3, we did non-invasive testing for fibrosis with that FIB-4. His FIB-4 of 2.22 is going to be an indeterminate range. So we know that if it's over 2.67, it's higher risk. If it's under 1.3, it's low risk. But this middle period, which is going to kind of constitute a lot of patients, we'll put them at intermediate risk or indeterminate risk. And further assessment is recommended with something maybe like a liver stiffness tool, perhaps transient elastography. And that's what this liver stiffness measurement tool or kind of comment is showing you here in step 4. For those patients, once you get idea of fibrosis staging based on blood-based testing and maybe imaging such as elastography, you could kind of then overall consider them either low risk for MASH and fibrosis, moderate risk, or high risk. And then that does help primary care endocrinology, GI, to determine, do they need to see a hepatologist or not? Is further evaluation recommended if they're moderate, or you can just kind of monitor and watch them over time. So he is considered indeterminate risk. What should you do next? Would you refer to hepatology for maybe further evaluation with liver biopsy or elastography. Would if you don't have access to a FibroScan or transient elastography, maybe that's what they would do at that clinic visit. But when he gets his FibroScan, 6.7 kPa, kilopascals, this now puts him at more low risk. So an indeterminate FIB-4 score, but a low FibroScan. Management really would boil down to lifestyle modifications, managing his metabolic diseases like his diabetes and his hypertension, hyperlipidemia, obesity. And then you still want to follow up and kind of surveil with repeat non-invasive tests like the FIB-4 and the FibroScan. So for the purpose of this presentation, someone with low risk or any risk, when we talk about lifestyle modifications and lifestyle management, what does that really entail? So just a quick overview of the continuum or the spectrum of MASLD. So, risk factors, overweight, obesity, diabetes, or other metabolic risk factors. We believe very likely that these people and these patients will have fat in the liver, steatosis. This can be more aggressive or can progress to steatohepatitis. Now we'll call it MASH, metabolic dysfunction associated steatotic or steatohepatitis. When you have MASH, we worry then you can have progressive fibrosis. If it continues and worsens, then this is what will lead to cirrhosis. And generally in the more advanced stages, that's when we worry about hepatocellular carcinoma or liver cancer. Besides the known metabolic risk factors and disease states like diabetes, et cetera, we also know there's some other things that both kind of nature and nurture, I like to say, with risk factors and pathogenesis. So, depending on diet, if they're intaking, high saturated fat, high fructose or high carb-based, diet, we know that this does increase inflammation. When we look at saturated fats and kind of the reactive oxygen species is at the biochemical level. Fructose will increase that, de novo lipogenesis, oxidative stress, and this is kind of the same driver for anything that's going to cause inflammation and progression in liver disease. But then genetics, do play a big part. We've science and in the field of fatty liver disease, we've really identified key risk factors or key risk genetic alleles such as PNPLA3, MBOAT7, MBOAT7, TM6. There are others, HSD 17B for Bravo, for example. And these also weigh in and kind of affect the spectrum or the progression of fatty liver kind of through different mechanisms and different means. So everything has a root cause. So, why are we in a setting where obesity is on the rise? Is that what's causing, or is that the effect? When we look at diabetes as well, and then again, the MASLD. But we know that they're all kind of interlinked. So, when you have someone who has MASLD or fatty liver disease, good chance and high prognosis or probability, I should say, that obesity and diabetes is there already, or it will eventually reveal itself. So, how do we get there to begin with? Why do people become obese? Why is there diabetes? And why do we have a fatty liver? So we definitely know that from a lifestyle standpoint, the nutrient intake, nutrition, exercise kind of component, this is where actually intervening and intervention and modification can occur. The energy exerted, nutrient, and good quality versus poor quality nutrition. This really is going to be crucial to really manage those patients that have MASLD and hopefully prevent it to turn into MASH or progression into fibrosis. We know that central obesity with just its own inflammation component, its aspect of insulin resistance, this specifically will also then affect the liver in a lot of ways, and this increases the risk of MASH over MASLD. So going back to Albert, you ask him a little questions on his diet and lifestyle, and he explains to you that he's primarily a Cuban ethnicity, so he eats a more traditional diet, a lot of rice, beans, pork, corn, beef, and plantains are just some of the staples. So knowing just kind of the nutrition aspect of things with improvement of fatty liver, how can we best discuss this with our patients and Albert specifically? How do we tailor dietary recommendations to culture preference and food accessibility or socioeconomic status? Of course, access to healthy, nutritious food is going to be something that needs to be concerned or aware of before you make recommendations. There are definitely people who will be vegetarian or vegan of preference, or identification. So this, is almost like a personalized approach to nutrition recommendations. His diagnosis remains the same. We know that any aspect of the treatment algorithm for MASLD and MASH, dietary change and exercise, is the frontline, first line mainstay of treatment, and it remains. And even with now a pharmacotherapy option, resmetirom, this is to be given in conjunction with the medicine, with lifestyle and diet and exercise changes. It remains the same in any clinical trials for MASLD or MASH, and it, in and of itself, it will improve and treat MASH and MASLD even if someone is not taking the medicine. I apologize for all these things. Weight loss is directly linked to improved histologic outcomes. It's been shown and proven. Multiple studies. We have a few footnotes here to kind of explain, but we know that a 5 to 10% body weight reduction actually can resolve steatosis, MASH, or even exert antifibrotic effects on MASH. So if we're talking about fibrosis regression, steatosis resolution, or even MASH resolution, weight reduction is definitely a key component of this. So in those patients that don't, it's not all nurture, but some of it's nature with genetic predisposition and polymorphisms. There's actually been some studies on more of a personalized diet and exercise program specifically for them. If you think of it as a prognostic aspect, these patients that have PNPLA3, for example, are higher risk, then their risk increases. Kind of the idea and how strict they are with lifestyle modifications does change, but also from a dietary standpoint, let's say, and cultural considerations, where can some improvements and modifications really get kind of focused on and intervene with. We know with exercise that anything that will improve weight loss and kind of be a sustained routine and regular program is really what we're striving for. So when we talk about things like aerobic exercise or resistance exercise, they both have key improvement or key and kind of more different aspects of how it improves health in general, but specifically fatty liver disease. There's been some studies that show that something like high intensity interval training, short duration, but maybe very high intense resistance training, it's not as effective, but we see in those settings it's more muscle building and muscle toning. It's not necessarily attributed or associated with significant weight loss or improved aerobic outcomes, but we do know that there's difference in energy consumption. So for aerobic exercise, it's going to activate lipolysis. We upregulate some of these cytokines and other aspects in liver metabolism, and it does alter all the cytokines and fat accumulation and otherwise. Resistance exercise, on the other hand, does improve in hypertrophy muscle fibers. There are other enzymatic panels and pathways that change, but together, just like anything, synergistic effect, aerobic plus resistance exercise will really benefit the patient the most for improvement or resolution of fatty liver into a more normal lean liver. We talk about a diet specifically, and this is something that we all will definitely discuss with patients and people, and not just to give a quick overview on eat healthier. We definitely want to be specific and detailed on what kind of diet we're referring to. But one of the mainstays and the keys with a friendly diet is going to be with the idea that we want to achieve weight loss. So we can all tell us that we've had patients that claim they eat a healthy diet, but they're not losing weight. Generally, one of the bigger considerations will be, are they really restricting or reducing their calories? So calorie restriction to actually achieve weight loss is going to be one of the big goals. Promotion of ketogenesis, so kind of altering how we burn, our metabolism works, how we burn fat, how we burn sugars. This is something that's important. So for patients on a keto diet, let's say, not just a fad, this can be effective if done properly. Is a genetic predisposition, those patients with it, is a specific diet more effective than others? Not necessarily, but we know that not adhering to a friendly diet is going to be something that's going to affect them, and put them more at risk than someone who does not have a genetic predisposition. The kind of the standard diet that we claim or quote or lifestyle is going to be what's known as the Mediterranean or heart healthy diet. The ASLD, the AACE, which is the Society for Endocrinology, and even European guidelines still recommend this as the approved or data-driven diet plan that will work if people are kind of following it and consistent with it for a long period of time. Ultimately, Mediterranean diet, low carb, low sugar, low fat diet, less calories. If we're talking, what is the standard caloric intake deficit that we want to achieve? We're talking, 500 to 1,000 kilocalorie from baseline. If we're talking, 2,000 to 2,500 is a standard recommendation for maintaining weight. We're going to have to be under 2,000 kilocalories is kind of detailed advice. So going back to Albert, knowing some of these factors on lifestyle modifications, and let's say we provided some to him, he came back for a follow-up with repeat lab testing. There really was no improvement, but he also admits that he has not begun really any exercise regimen. He tells you he has been trying to cut out soda, but what does that mean? And do we know what his baseline was versus what he is at now? So how do we work with patients to create behavior change? And this is something that, again, we're not just thinking of a diet or lifestyle modifications as a short-term solution. We do want something more long-term and consistent for many, many months, many years to come, and ultimately leading to a more healthy lifestyle for the rest of someone's life. So what can we do to help create behavior changes? There's a lot of concepts with not just with exercise and nutrition, but addiction as well, motivational interviewing, diary keeping, something that's going to be, whether it's technological utilization of apps and other components. But there's a lot of things that if we consistently, especially as providers seeing these patients, if we can keep on them and make this the focus on actual examples and details and what's changing from one visit to the next or one time point to the next, this will kind of create this positive feedback and kind of positive aspect of the patient to kind of keep striving for goal change. One kind of validated tool or scale that's been studied in fatty liver specifically, it's what's called the Exercise and Diet Adherence Scale, or EDAS. This is pretty much questionnaire based, 33 items, kind of covering 6 major topics of lifestyle and just habits. And this was something that was studied over a 6-month period. And this kind of questionnaire, though, allowed for people and kind of self-report, but also report to providers their exercise regimen, their calorie intake. And you can kind of then see quantifiable changes as something that would predict and should allow for someone to lose weight and improve their fatty liver. This is something that could be extensive for some people if they don't have ideal understanding of reading and writing or this is very much designed for simple questioning, nothing medical in nature, but not easy to do in a clinic setting necessarily. But it is something and a good example of how we can kind of track and again quantify what someone is doing. Just even simple diary keeping or other tools have also been shown to be effective, but something that is validated is always ideal. So in kind of conclusion, for lifestyle management for MASLD MASH, we definitely know there's risk factors, metabolic disease-wise, there's genetic predisposition and polymorphisms. And to manage and to modify, we need to look at, kind of all these features overall, and then ultimately, kind of not only educate and advise on a more healthy diet with more of a Mediterranean or heart healthy approach, increasing exercise in both an aerobic and a resistant manner. But we need to be able to make sure patients are adhering, and there are some tools that you can use to help prove that. But a lot of this is going to be behavioral change in orders. That aspect of managing patients is something that is not a one-time visit. This will take much time to get through to them. I want to thank everyone for listening in. I hope this was something that weighs well on you guys. Hopefully you've learned a little bit of something, and always happy to add on if there's any specific questions.